prospectively monitoring our patients have actually changed the game for us in our own unit. Right, so you guys are obviously all familiar with the rates of prevalence of malnutrition in our setting, and in Africa it's obviously, it can be quite high, as up to 60%, and we know that it's dependent on several factors that can influence the development of malnutrition, even at diagnosis already, and it obviously includes things like the malignancy, the cancer type of treatment that they get, the side effects from the treatment they have, and then that in turn influences whether they can eat and tolerate oral intake, whether we have to go to other routes to feed our patients, whether they even have access to food in the first as well, and then obviously diagnostic techniques and what we actually use to classify malnutrition is also something that's been described a lot in the literature in terms of what we find or how we describe the prevalence of malnutrition in our units. And this malnutrition obviously also includes the double burden of disease. So it's either end of the spectrum. So it's not just the classic malnutrition in terms of undernutrition, but it more and more with the westernization of diets, etc. We do see overweight and obesity creeping in, and not just in the higher income countries, but also in the lower middle and lower income countries as well. So obviously the substantial impact from malnutrition that we do have will influence the quality of life, the prognosis of our patients, which can then result in impaired wound healing, the risk of infection, treatment delays when it gets postponed, and it can also result in treatment tolerance and your response to the treatment. And this will then in turn, if you do survive, you can also struggle a little bit in terms of experience other sort of side effects and even secondary malignancies later in life. So all in all, our most important goal, almost as nutrition or as the multidisciplinary team, would then be to identify the malnutrition early on and then try and treat it as effectively as we can. But something that often when we talk about malnutrition and how we're going to treat it on a ward round, we do often forget that it also has an impact on our chemotherapy tolerance, which is one of the biggest side effects that we struggle with on a daily basis. And I just thought it's important to highlight that when we work out the chemotherapy dose that we are going to give, the body surface areas based on anthropometrical measurements, such as weight and height. But the clearance and the metabolism of chemotherapy agents also actually mostly depend on your fat-free mass. And if you should have any sort of malnutrition, whether it is a diagnosis or whether it develops through your cancer journey, if that influences your fat-free mass and your muscle mass, which is then the largest part of the fat-free mass and is metabolically active, that can ultimately result in this increased potential to develop chemotherapy toxicity. And then it's this sort of evil cycle that continues. So it is well known, but the ability to then treat or to reverse this malnutrition that we do experience can be described as being inversely related to the intensity of the chemotherapy. So we know there are certain disease types and groups and high-risk disease settings that experience or that are more prone to develop malnutrition and a more severe form of the malnutrition as well. So it is important for us to then differentiate between body size versus body composition. For this specific reason is that we can't necessarily quantify functional tissues or fat mass when you only look at our anthropometrical status and those sort of variables. So there is an argument obviously for the arm anthropometry, but to be a little bit more accurate than our standard weights, heights, and BMIs when we measure. But if we look at the diagram to the right-hand side, it is important that we do see what a large part of the body, total body weight, actually is made up of the fat-free mass, and then specifically the muscle mass or the skeletal muscle mass, and why it is important to try and add some sort of an advanced body composition analysis together with your anthropometrical assessments to be able to identify the true extent of the malnutrition that we are experiencing in our unit. The next question also then becomes when are they more prone to develop this malnutrition? And there isn't a lot of evidence to describe malnutrition developing over time, most of the literature does look at malnutrition at diagnosis, and then it's linked to survival and your prognosis ultimately. But these, as time went on, from about 2015 onwards, you do get some nice research that does describe the development of malnutrition over time. And most of these studies look at measuring their patients in 3 monthly increments. And what they've actually found is the first 3 months tends to be the most detrimental in terms of depletion of nutritional stores. And NES does this. It's a study from Scotland, for example. In the Netherlands, they classified their patients with more than 5% weight loss as being severe. And if you experienced quite severe weight loss specifically, it definitely had an impact on your survival. The good news, however, is that there is a light at the end of the tunnel. And if you do improve your nutritional status, you can have a similar 5-year survival rate to those who never had malnutrition to start off with. And that is basically the rationale for what we try to look at in our study here in Cape Town. So try and identify when our patients are most vulnerable for the development of malnutrition once they're exposed to chemotherapy, in order for us to treat it more effectively. And then we monitor the anthropometrical status and the body composition together to be able to see the severity of the nutritional depletion. So I formed part of a larger ongoing PhD study from Judy. It is a prospective cohort, and it was we saw everybody at the pediatric oncology unit in our unit at Tygerberg Hospital in Cape Town. We saw both in and out patients, and they were all newly diagnosed patients that came to the unit during the period of 2019 to 2020. We measured them according to their individual treatment regimens. We didn't incentivize any additional trips to the hospital. So we only measured the ones that we had access to, whether they were inpatients, whether they were actually admitted to the hospital. So our assessments therefore included the anthropometrical status, and we looked specifically at weight, height, BMI, and our MUAC measurements. We did not include the tricep skin folds, even for the largest study. The rationale eventually was that the children were so afraid of getting the tricep skin folds measured, and we already had to measure them with the body composition. So at the end, we opted to go with the MUAC only. We looked at absolute values, changes over time as expressed in percentages of each other, and we also used the WHO's Z-score classifications. For the body composition, the device that we used was called the InBody S10 bioelectrical impedance machine. It was a mobile unit. It involved quite a few measurements, but for the study, we specifically only looked at fat mass, fat-free mass, the skeletal muscle mass, and phase angle. There we also used the absolute values, and the actual device is also pre-programmed with the interpretation of the variables in terms of whether they were high, low, or normal values. You could possibly say there is a lot of discussion surrounding the use of these various BIA models, but we did feel confident with the one that we have chosen because it is a multi-frequency model. It does measure the 5 segments. It was validated in 4 pediatrics against DEXA as well. So we were quite confident when we used this specific device, and it was more like a child-friendly sort of looking device. I thought I'll just show you a picture of what the electrodes, the tactile electrodes, look like. You could also use little stickers with the crocodile prongs for small children less than 1 year old. So the compliance of them actually having to sit still for the standardized measurements and techniques or lie still, we were able to really achieve that. And obviously lots of baby shark videos and singing along and entertaining them for the 2 minutes while we took the measurements to make sure that they lie absolutely still. So if we look at the measurements that we've taken, we did them at diagnosis prior to the initiation of chemotherapy. We also measured the children before hyperhydration even started. And then we took these measurements and repeated them for each patient on a monthly basis as they visited the hospital. And we then plotted and compared them specifically to each patient's diagnosis values to track the change over time and to see whether they were improving or not. So fortunately, we ended up not having any missing data. So we measured them consecutively up until the end of their own respective chemotherapy treatments or up until the potential for death. And these patients then, so some of the sort of low risk patients, especially the smaller children that didn't require as much chemotherapy, like with some of the nephroblastomas, if they only had they received their chemotherapy cycles over a period of 3 months, we only have 3 consecutive measurements, which we then included up until the last measurement. And we used a bit of summary statistics. We used the non-parametric methods to check for significance in change over time, and we used a statistical significance of 5%. All right, so we had 47 newly diagnosed patients that presented to the hospital during this time frame. We had to exclude 4 of them because they did not require any chemotherapy, only exclusive radiotherapy or surgical interventions. So in the end, we had 43 patients and 5 died during the period that we collected data, and then 6 of them only required less than 6 months of treatment. So in the end, only 32 patients had 6 measurements in total. We found that we had a median age of about 4 years. We included everybody aged 3 months to 15 years because this, just from a practical perspective, this is the age groups that are actually admitted to our pediatric oncology unit before they go to the adult ward. Otherwise, we would have included the children that were a little bit older. And our male-female distribution was almost equal in this case. We also stratified for cancer types. So the hematological malignancies, we had 23 participants, of whom the ALLs basically contributed to half of this group. And the solid tumors, we had 20 participants, so almost an equal spread there as well. And the nephroblastomas contributed to about a quarter of the participants that had a solid tumor. So it was quite interesting when we look at our results at diagnosis, is that our prevalence of malnutrition was a little bit lower than presented in previous research, specifically in Africa and also all over the world. It varied depending on the anthropometrical variable that we used, and we can see, as we know now, that MUAC tends to be the most sensitive, and it does identify more malnutrition, specifically undernutrition in this case, when compared to some of the other variables. Our overnutrition compared well with what we've seen in international studies as well, from both high income and low income countries. And interestingly enough, our population didn't really suffer from chronic malnutrition or stunting. The stunting is about 25 to 27% in South Africa for children under 5 years. So our population was quite less than that. So in total, we could say that the prevalence of malnutrition in this little population, we had less stunting and overnutrition than the standard South African rates, but we had double the amount of undernutrition. And we do know that the presence of cancer at diagnosis is enough to cause some sort of an acute weight loss. It's also interesting when we compare to other literature published in South Africa, they also presented a far higher prevalence rate of undernutrition, but I do think the fact that we've included hematological malignancies made or helped the fact that our malnutrition rates were not as high as previously reported. Okay, when we look at the body composition results from the in-body machine that we have used, you'll see it's a much different picture, and it's a lot more severe when you look at the underlying derangements that anthropometrical measurements were not able to pick up on. So, and interestingly enough, even though we did have some form of overweight or obesity, fat mass was also classified to almost half the participants had a low fat mass right at the beginning, and it was distributed equally among your hematological patients and your solid tumors. And if we look specifically at the skeletal muscle mass, we can also see there's about 19 patients that were classified with a low skeletal muscle mass before the chemotherapy was even initiated at diagnosis. So very, very important. The anthropometrical status in this case was not able to identify the true extent of the underlying malnutrition in this case, specifically when we look at the functional tissues, and we know that that's the one that we're really worried about when it comes to chemotherapy clearance and tolerance of our patients. So I just wanted to highlight this as well. If you compare them directly, we know that MUAC is more sensitive than some of the other anthropometrical variables to identify malnutrition, and it did, in fact, identify more malnutrition in terms of the undernutrition than the other variables that we have used. And because it's a known surrogate for skeletal muscle mass depletion, or stores rather, it is interesting to see that even though it did identify the highest amount of undernutrition, it still couldn't quite identify the true extent of the underlying skeletal muscle mass depletion that our patients have experienced at this point, which was something that I didn't quite expect. So when we look at our changes over time, so this was diagnosis, now we've introduced chemotherapy. It was interesting to note that the existing malnutrition was not as severe as we expected, or when we compared to previous results, but it really did deteriorate a lot after exposure to chemotherapy. And this is true for all variables other than the fat mass, and I'll show you some of our graphs now, and this is possibly to be expected based on previous research. The most important thing that I just want to highlight is that all of this happened despite very intense nutritional support right from diagnosis, counseling. They received early enteral nutrition. They received appropriate TPN. I think when Judy presents her results to us, she will go a little bit more into detail in terms of what exactly we did for our patient population. But this acute exacerbation of existing malnutrition was quite severe despite the proper nutritional support that they've received right from the start. Okay, so when we look at our trends in weight over time, it is interesting to see that our weight is most affected in the first month after treatment, or the first month after our chemotherapy exposure. And it takes about 6 months to change over, and I'll show you the interpretation of the growth right at the end. But also important is to show the difference between the two main types of cancer diagnosis, or cancer type in this case. So we weren't able to stratify for high-risk disease because our patient population was not large enough. But in this case, I do think this does visually represent what our patients go through and what the different types of cancer patients go through from a weight perspective, just based on the different types of treatment regimens that they also follow. And you can see there that the increase in weight for the hematological malignancies, which is represented in the red dotted line, is quite pronounced. And if you look at some of the literature and some of the guidelines that they tell us, is that you have to start with early counseling with the patients as well, but most of the guidelines don't actually include weight maintenance or healthy eating guidelines necessarily right from the start, or checking your weight at least right from the start. And here we can see that these children are predisposed to being overweight and becoming obese, like literally in the first month of their treatment already. I didn't include the height measurements here because even though they were static, we did see some improvement in the height over time. But I wanted to show you the BMI trends of what we found, and you'll see also, once again, anthropometry most affected during the first month. And interesting here, even though the hematological malignancies tended to gain weight right from diagnosis already, it did affect their BMI similarly to those of the solid tumors in this case. However, if you give them enough time, you'll also see that the increase in weight gain translates to an increase in BMI, and it is something that happens quite rapidly right from the start as well, from diagnosis. So in terms of healthy eating, weight maintenance, in terms of counseling our patients to expect these detrimental side effects from happening right from the start already, and having good habits is just being proven by these graphs where we see the immediate effect of the treatment that they would be receiving. I also had a question from one of the examiners in my exam in December, where they were suggesting that maybe the decrease in weight and the decrease in BMI right in the beginning experienced by the solid tumors are in fact based on the fact that the solid tumors potentially shrank during the exposure to chemotherapy. So I'd actually like to hear your guys' opinion about that. We've discussed it among ourselves, and we've decided that it's not necessarily the case, since most of these patients had to wait a little bit to get their tumors excised at this point in time. And if we look at the overall weight gain over the 6-month period, you'll see that the patients with solid tumors did in fact manage to gain weight, even though the BMI decreased. So, I don't know if it's probable that it's just the shrinking of the tumor that's influenced the loss of weight and the BMI in the first month in this case. Okay, when we look at MUAC trends specifically, you'll see for the first time ever, both groups of cancer type experience the same loss of muscles or of functional tissues in this case. And if you look at the all cancer type, which is the blue line, I've just interpreted there for you. When you see it visually, it does look severe, but if you look at the actual value, it's only about 0.7 centimeters that they've lost as a mean loss during this point in time. But if you express it as a percentage, you can see that it can almost be classified as quite severe in the bigger picture. So my suggestion here would be that if you do see a small, even if it is a small change in mid-upper arm circumference, it's possibly a sign of a much larger loss happening in the meantime, and when we look at our actual skeletal mass values at this point in time. So even though the hematological malignancy started to gain weight relatively rapidly right from diagnosis, they were also prone to quite severe loss in functional tissues, just as our solid tumors were after they were exposed to chemotherapy. Okay. The interesting part that I'd just like to highlight here is that anthropometrical variables seem to get depleted or seem to change the most during the first month of chemo exposure, whereas the body composition variables were most affected during the first 2 months after chemotherapy exposure. So the effect on the body composition lasted a lot longer than it did with the anthropometrical variables. And in this case, you'll see once again the pronounced difference between the different cancer types. In this case, hematological malignancies, which is interesting, even though they started to gain weight, the fat mass in particular was only affected from month 3 onwards. And it's interesting to see that even though they experienced about a 1.2 kilogram overall increase in fat mass, which is about almost a 48% increase, which for me it is clinically significant when you would look at them, when you would greet them, when you would just ask them about their day, ask them about their dietary habits. You wouldn't necessarily know that the fat mass is the largest contributor to their overall weight gain at this point in time, which just illustrates why there is such a big need for further body composition measurements in these patients. And even though it is clinically, the increase in total from diagnosis to month 5 was clinically significant, it was still not deemed statistically significant in this point of time, which just highlights that we really need to look at the body composition and take that into account when we do counsel these patients and when we do assess their progress overall. And yeah, so fat-free mass specifically also affected most during the first 2 months of chemotherapy. A very large difference between the solid tumors and the hematological malignancies at this point in time. And this is important, as we've said, because it would influence our chemotherapy tolerance at the end of the day. So I'd want to spend a little bit more time when we look at skeletal muscle mass specifically. And even though it gives us a similar graph specifically when we look at our solid tumors here, you can see that when we look at skeletal muscle mass, the hematological malignancies are also affected, albeit not to the same extent that the solid tumors were affected in this case. This then obviously links to our mid-upper arm circumference results, which we've also seen, so that both cancer types experience a drop in our functional tissues. And in this case, when we look at our median value for our all cancer types, it does come to about 700 grams, which was, if we look at our median loss, that translates to about 12.5%. So in terms of functionality, in terms of being able to play, sitting up, walking up and down, just functioning like a normal child would, they would lose quite a bit of that function right from the start as well, and it affects both cancers. So yeah, just highlighting the fact that a change in body composition should be noted, and we should really take that into account when we look at our patients, because we'll be able to give so much better input in terms of what their dietary requirements would be. But I'm getting ahead of myself now. I just wanted to show you when we use the classification system of the skeletal muscle mass, it also showed us that about 62% of our participants were classified with a low skeletal muscle mass during the first month after diagnosis. So even though our graph may not show it, or may not show the severity of the loss in our hematological malignancy population, it would be interesting to note that the hematological malignancies were equally affected by the classification of a low skeletal muscle mass at this point in time. And it would also be interesting to see that about 40% of our population came in with a low skeletal muscle mass, and despite all of these nutritional input and support that we've given, and counseling, and being able to give them accurate counseling based on each individual's change in body composition over time, we were still not necessarily able to really have an improvement in skeletal muscle mass by the end of the 5-month follow-up, just showing that the initial losses in our functional tissues are quite profound, and it can potentially remain despite the overall improvement in absolute values, or if you express it in a percentage change over time. So just to summarize then, we did find that despite all of these changes, the nutritional support that we did provide the patients and the counseling managed to introduce a significant catch-up growth or improvement in our nutritional stores over time. But this, however, was not true for the mid-upper arm circumference, for the fat mass, and for the phase angle, which is quite interesting, because the phase angle you could also use as a sort of like a raw parameter, which is not influenced by tumor mass or by hydration status either. It's something new that's popped up in the literature. I struggled a little bit in terms of interpreting it, because we don't really have cutoff values yet for pediatric oncology, but it is linked with our functional tissues, as is MUAC in this case. And if you look at our skeletal muscle mass, we were only able to gain about 300 grams in total over the 6-month period in anyway, which does show that the severity of the nutritional depletion in terms of our functional tissues are quite intense, and they may not necessarily improve for everybody over the 6-month period. But as we've seen with some of the previous studies that I've spoken about, we were actually able to see an improvement, and we didn't, even though we didn't follow them up for a longer period of time and looked at survivorship, etc. Hopefully, the fact that we were able to see some improvement would link with previous literature to show that there would be an improvement later on in terms of prognosis. So I would just to summarize, I would definitely recommend that we be on the lookout for nutritional deterioration during the first 2 months of treatment. And this is exactly the same as some of the previous literature that I've quoted. So the first 3 months of treatment is definitely the highest risk period for developing malnutrition and body store depletion, and specifically our skeletal muscle mass in this case.